Okay.
Great. So welcome everybody once again. Now the webinar has been recorded. If someone does not wish to be recorded, you can go ahead and turn your cameras off. Otherwise, it will be uploaded on our website, the Cupid project website. Myself, I'm Oliwia Kowalczyk from Nicolaus Copernicus University in Poland, and my colleague and friend, Dr. Margaret Deny from the University of Maribor. We're going to speak today about augmentative and alternative communication and its role in cancer prevention and screening, especially for people with intellectual disabilities. I will take the first part of this webinar, and then Margaret is going to share with us her really, really valuable experience from last month in Slovakia in this area. Okay, so if there are no objections, I'm ready to start. Margaret, can I start, or do you want to add anything? No, okay. So thank you for the first slide. I will focus on communication as a health equity issue, and we can go ahead and do slide 2, please. So I will start with some introductory words. There is a population of people numbering between 1 and 3% of the global population who are dying of cancer at rates we could be preventing. And it is not because we lack the medical knowledge or not because the screening tools don't exist, but because the information environments we have built around those tools were never designed with those people in mind. I would like to start with this information because everything we'll discuss in the next minutes in our webinar flows from this structural failure. We can move on to the next part, but please leave the previous slide. People with intellectual disabilities have faced profound and well-documented inequalities across the entire cancer care pathway. In 2022, our friend Martin Cyprus and his team published a landmark national-wide cohort study from the Netherlands, one of the most rigorous population-level analysis we have in this field now. And it found that cancer was reported as the cause of death approximately 1.5 times more often among people with intellectual disabilities than among their non-disabled peers. And critically, the largest disparities were concentrated precisely in the cancers for which screening programs exist. And that finding is not a coincidence. More recently, in 2023, systematic review by Amina Banda and colleagues, consolidating evidence across multiple countries and cancer types, also confirmed that people with disabilities receive less guideline-consistent care, have less access to specialist services, and experience higher cancer-specific mortality than people without disabilities. So the mechanisms are multiple, but access to screening sits at the center of them. Next slide, please. Now, when we look specifically at cancer screening participation, the numbers are stark. Another colleague of us who is a member of our Cupid project, Kate Sykes, in her work in 2024, she used the most current NHS England data, and she found that for cervical cancer screening, uptake among women with learning disabilities stands at 31% compared to 67% in the general population. For breast cancer screening, it is 47 versus 62. Another systematic review and meta-analysis by another team of researchers in 2022, spanning 29 studies from high-income settings, confirmed that these disparities are not a UK phenomenon. They are consistent across healthcare systems. Another systematic review, also published in 2022, identified the barriers driving these disparities. They are not primarily clinical, they are communicative. They include lack of accessible health information, difficulties understanding the purpose of screening, and inadequate support during the screening process itself. So we should be very precise here, and because we are not saying that people with intellectual disabilities cannot understand cancer screening. We are rather saying that the standard communication systems, the letters, leaflets, clinical consultations, are built for a reading age and a cognitive framework that many people with intellectual disabilities just do not share. The problem is not the person, the problem is the information environment. And we do believe this is a fixable problem. So let's move into the communication science, because understanding what has gone wrong requires us to understand what communication support for this population actually looks like when it is done properly. So let's begin by, thank you for this slide. Let's begin by doing something important, which is to define our terms precisely, because augmentative and alternative communication is a phrase that is often used loosely. And during this webinar, we need to be working with the full weight of what it means. So AAC encompasses, as you can see in this slide, all forms of communication that supplement or replace conventional speech and writing. That is the definition from both the American Speech Language Hearing Association and the International Society for Augmentative and Alternative Communication. It is not the last resort for people who just can't communicate. It is a sophisticated, evidence-based field of practice that meets people where their communicative capacities actually are. In practice, AAC operates across two broad categories. On one hand, on the level you have unaided AAC refers to systems that require no external device. So we have body language, gestures, formalized signing systems, like Makaton, for example. And on the right, you have aided AAC that refers to any system that uses an external support. At the low-tech end, communication boards, symbol cards, easy-read materials, and at the high-tech end, speech-generating devices and dedicated AAC applications. So for people with intellectual disabilities, best practice is multimodal, which is combining several of these approaches simultaneously, and what's very important, tailored to the individual. Next slide, please. What is clinically essential to understand about this population, and what researchers articulate clearly of AAC use in clinical consultations, is that people with intellectual disabilities are not a homogeneous group. The communicative profile ranges from individuals with mild intellectual disability who read fluently and need only modest adjustments, to those with severe or profound disability who rely entirely on aided, partner-supported communication. So any intervention, including a cancer screening program that treats this population as uniform, will fail just most of them. There is one concept I'd like to share because it is both clinically significant and frequently overlooked. That is the asymmetry between receptive and expressive language in many people with intellectual disabilities. As you can see in the slide, receptive language is what a person can understand, and this is often substantially stronger than expressive language, meaning what they can produce or communicate back. So the clinical implication is profound here. A person may understand far more of what is being said to them in a screening consultation than they are able to articulate in response to the healthcare providers. So if a clinician reads that silence as incomprehension or as lack of interest, well, they have misread the person entirely. So this is one of the mechanisms through which diagnostic overshadowing, which is a well-documented phenomenon in this population, just takes roots. Next slide, please. It can be framed clearly through the concept of health literacy, which I'm sure you are all familiar with, and specifically what we call social context of health literacy for people with intellectual disabilities. Health literacy is not simply the ability to read a leaflet. It is the capacity to acquire, to comprehend, evaluate, and to apply health-related information. People with intellectual disabilities face what we can only describe as a double burden. We have here reduced baseline health literacy and information environments that assume high literacy. So researchers like Chin showed in this slide argued that the problem is not within the person, it is in the gap between what the health system communicates and the communicative resources the person has available to receive it. Another review on AAC partnership with people with severe and profound intellectual disability, also found shown here in the slide, found something that resonates beyond that specific population, which is that effective communication requires a shared commitment between the person and those around them. It is just relational. It is not a matter of handling someone a symbol board and just walking away. It will not work. This has everything to do with cancer screening that we work on in our Cupid project, because screening is not a passive act. It asks a person to understand a concept that they might have something wrong with them and they cannot feel it. And it asks to consent to an examination. So that requires communication. And that communication just needs to be designed and tailored for the cognitive abilities. Next slide, please. So what does the evidence tell us about designing it well? I put a few titles here, a few authors and their research. Let me briefly introduce it. This is where the picture becomes both encouraging and honest, because the evidence for accessible health communication is real, but it also asks us to be precise about what works and under what conditions. So these few examples show the answer to this question. The most comprehensive source we now have is the first of the presented works. The review confirms something that we need to hold on to. Up to 95% of people with intellectual disabilities have reduced health literacy and literacy levels, and between 60 and 90% experience receptive and expressive language difficulties. So the communicative case for accessible health information is not speculative, it is just established. Next is Easy Read, which is written information adapted through simplified vocabulary, clear layout, supporting image, concise content, according to the rules that the countries have. It is the most widely implemented communication adjustment in health setting, but researchers are careful to note wide variability in quality and in how materials are developed. And this connects to a finding also presented here in the slide, and showing that At that time, the evidence for the effectiveness of Easy Read was insufficient when it was written by the research team. High quality evidence for enhanced comprehension, knowledge transfer, and behavior change was just limited. And that finding has not been fully overturned nowadays, but it has been contextualized by subsequent work. In particular, a randomized controlled trial presented here as well that found that simplified language combined with mediation, that is skilled facilitation and exploitation by a trained communication partner, produced significantly better outcomes than either simplified text or mediation alone. So the lesson is not that Easy Read doesn't work. The lesson is that Easy Read without facilitation is just incomplete. A leaflet sitting on a waiting room table is not an intervention. An Easy Read material delivered by a skilled facilitator who supports comprehension, who checks understanding, who creates space for questions would be an intervention. The next study in this slide found that Easy Read materials were actually used in only 22% of primary care health checks, despite being available. So this is the implementation gap. The tools exist, the evidence base, while still developing, is sufficient to act on. The barrier now is the gap between what is produced and what is actually deployed in clinical practice. Next slide, please. So the most important process, or the most important finding of all those works, is co-production. Studies of inclusive research in health and social care confirmed that co-researchers with intellectual disabilities contribute really meaningfully and substantively to research quality and to material development. Easy Read resources designed without the involvement of people with intellectual disabilities consistently just underperform. And this is not a design preference, it is an evidence finding. It is also an ethical and rights-based requirement. So what we have then is a clear chain of reasoning, a population facing preventable mortality from screening accessible cancers, a well-theorized account of why standard communication fails them, and an evidence base for what accessible, facilitated, co-produced communication can achieve. What we do not yet have is a real-world documented models of what this looks like in a room with people with intellectual disabilities. Talking specifically about cancer, as far as our project is concerned, for example, and our main interest. And that is precisely the gap that Margaret's work addresses, and Margaret will share her valuable experience with us in a few moments. I'll go on to the next slide, please. So before we can hear and see this implementation of this approach in real practice with people with intellectual disabilities in one room, let me just draw together what we have covered for now. We have a population with a documented mortality disparity in cancer, concentrated in precisely the cancers that screening should be catching. We have a communication science that tells us why the existing information environment fails this population and what a better one requires. And we have an evidence base that points clearly toward facilitated, multimodal, co-produced communication as the approach most likely to bridge this gap. What the literature does not yet give us and I was trying to show it in one of the slides a moment ago, is documented examples of what that approach looks like in practice, specifically in the context of cancer and cancer screening, specifically delivered in community settings, and specifically in Central and Eastern European contexts, where we all come from, and where both disability policy and cancer screening infrastructure present distinct challenges. So last month, Margaret took these principles into a room in Slovakia, designed and delivered an easy read workshop. So now it will be our pleasure, Margaret, to have this opportunity to listen to how this practical approach can be delivered and achieved. And I think it will be a really good lesson for all that deal with this topic and this research area and work with people with intellectual disabilities. So the floor is yours, please.
Thank you, Oliwia. That's absolutely brilliant. You have covered all the empirical evidence supporting why we should do this. And now I'm prepared to actually showcase what has been done together with Oliwia in terms of showcasing our work in WG1 as co-leads in this Cupid project. And I'd like to thank Oliwia for an excellent presentation.
Thank you.
So the workshop that I delivered was in a special school, and I can't remember the name, but I have it on the acknowledgements on the Cupid website, where all the information about that workshop, and it was delivered in Kostice, Slovakia, as part of an STSM for the Cupid project. And I was kindly hosted by Professor Gabriela Stefkova at the University of PJ. I'm so bad on pronunciations. I'm not a linguist. Shafarik. The session aimed to provide an accessible, co-produced approach to cancer prevention and screening education for people with lower and higher support needs as direct participants in this workshop. And I thank the vice principal and principal of that special school for affording me the opportunity, and indeed a colleague on the working group 1, Oliwia, she also facilitated this workshop with me because she translated what they couldn't understand of my Irish language. Even though I'm in the University of Maribor, I still have an Irish sounding language. So I'd like to thank as well the Cupid chair and the project manager, Francoise, for organising an easy read training last year, which I undertook and made me somewhat competent in terms of delivering this workshop. I think it was Easy Read UK did the training. I'd like to thank Dr. Kate Sykes. Thank you for informing us about the Easy Read checker. So you can input your document or your PowerPoint for a comprehensive compliance check against 50 checkpoints across 4 categories in terms of Easy Read. So we have the link at the end of our slides where you can do that, or you can replicate our slides on this presentation and carry out a workshop, but just acknowledge us as having put them together. So the aims of the workshop were to explain cancer using Easy Read and AAC approaches. And I think Oliwia gave an excellent introduction there to the AAC. Increased their understanding as participants in terms of understanding cancer screening, and discuss augmentative other communication approaches as well, and promote participation with confidence in their healthcare interactions if they're undergoing screening. So the workshop delivery itself, the session was delivered using an easy read language and repetition. We had it one slide in English, one slide in Slovak, and they were very slowly gone through. We used visual supports and symbols. We used interactive discussion. And in fact, we started the session with some music to make them feel relaxed, and we laughed and we sang and we danced a little bit, and then we got to the serious stuff. We had real life screening pathway examples, and all attendees engaged in discussions about communication, their fears about cancer screening, and understanding of the healthcare processes if they were to go into.
I think one of our participants has the micro on. Thank you.
Okay. Yeah. So attendees engaged in discussions about communication, their fear of cancer screening, and understanding of healthcare processes if they were to go for cancer interventions or preventative cancer interventions. AAC tools were demonstrated in both low-tech picture boards, as Oliwia talked about, and symbol cards, and high-tech communication apps supports. So I'm just going to run quickly through the slides to give you some idea of what we actually did. So I'll fly through these if you don't mind. Oh, doesn't want to go. Yeah, so that's beautiful Costiche. I just took that photograph. It's so beautiful there. And that's the classroom where we had the workshop, and the workshop went on from about 8:30. We had refreshments there, we had music, we had song, we had dance, we had everything. And Olivia is over on the right-hand corner there of the screen, and she actually helped with the translation. Now, we had support people there helping explain, and when we had discussions, they engaged. So we talked, we decided that it was in terms of inputting this PowerPoint into the easy read, they suggested ways of talking about cancer and cancer screening. And I showed them where I was from. Then you can see we asked for consent to take photographs and put up on our project site, and they all willingly agreed. And I'll go through these very quickly. I'll just stop at the more important ones. And I told them I was going to ask them to answer a few questions, and then we went down through cancer prevention services for people with intellectual disabilities and why they were so important. We spoke about the Cupid plan and what we were doing there, what we want to do and all the countries involved. And then we looked at cancer, and we tried to, with my colleagues, we tried to explain what cancer is, and we put it in a very simple language in terms of the cells, and when the cells don't grow too fast, when the cells grow too fast, and they really found that interesting to understand it. And then we looked at why people with intellectual disabilities or with higher or lower support needs don't attend screening. So we discussed that, and they had many reasons. They don't understand, they feel fearful. So there's a lot of areas that by going out and doing workshops, we can feed into the problems in terms of attendance at screening programs. Cancer screening, I explained all that to them, and finding cancer early, why it was so important. And then Oliwia and I, last year when we were doing the Prague workshop, Oliwia sourced the breast cancer and screening, because I know she's really excellent at doing presentations on breast care and screening. And I showed them that book in English and they absolutely loved it. They felt they were going to translate it and distribute it to families. Well, I don't know if they can do that. I asked them to get permission from Macmillan. So then we talked about chatting and how does that help with cancer. And cancer screening helps them to understand information and their results. And then they had a problem talking with healthcare staff, and we also discussed that can be very hard and how they could overcome that. And talking in different ways, and we moved into the AAC and how it helps with screening. And then we looked at all the different modes of communication. And now, needless to say, we stopped for many breaks and we had coffee and we discussed things. Yeah, and it was just great. And that was a link to a low-tech talking system that we went through. And then we looked at the high-tech and ways of these and how these ways of AAC can help with talking and helping in screening and cancer prevention. So we went from the time they received the appointment letter to the results. And they were delighted with that, really and truly. And what happens at a cancer checkup, and the cancer checkup, what the doctors look for, and then talking to the doctor, that you can use pictures or symbols, you can say how you feel, and you can ask questions. And if they should have symbols for pain or feeling sick or scared, and that at any time during this process they could use, so they are in pain, help, stop, or scared. There were the three words we emphasized. If the doctor was engaging with them, they could use it. And if they were having, say, mammography done, they could also use those words. And then that they have access to support. And so today we concluded by talking about how we can make cancer screening and healthcare easier. And together we can improve cancer education, change how cancer screening is delivered. And I truly believe that. And I ask them to stop and think about their own health, know about cancer, have a cancer health check, and that together we will find answers. And we looked briefly at the WHO 5 factors or pillars of cancer prevention. So to reinforce that area in terms of prevention. And then I thanked them, and at the moment then that moment, Oliwia and I have developed an evaluation protocol for services in terms of how are they doing in relation to cancer prevention. But we also developed an evaluation protocol, an easy read for persons with intellectual disabilities and or higher or lower support needs, so that they could understand and give us feedback on what they thought of the evaluation protocol for people with ID to give back feedback to the services in terms of how they are doing. So they filled out that, which was great. And yeah, that was the end of the workshop. So if we conclude, how do we bring all this together? Well, I think the ecological model in terms of the Brunfen-Brenner's ecological model, we need to come at it from a macro system, a micro system, and a meso system in terms of equitable access to population-based screening participation with peers, that it's equitable with the peers without intellectual disabilities, and that people with higher or lower support needs can access this treatment, this prevention. Okay, I don't know why my screen won't move on. Sorry, now folks, it just, for some reason, yeah. So if we go back there, it's a multi-level framework for change. The workshop findings can be interpreted using a multi-level ecological approach. It highlighted that change cannot occur at one level alone, but at many levels. So at the microsystem, immediate environments of direct interaction. At the mesosystem, linkages among microsystems such as the home and school relationships, like what we did. That's the mesosystem. And the exosystem, indirect setting like parents' workplace or local policies that affect a person via others. And then at the macro system, the overarching cultural, legal, and economic frameworks shaping values, barriers, and opportunities. So I'll just go back there. So if I can summarize that, some key observations. Just one second. The workshop demonstrated that participants, some with higher or lower support needs, engaged more effectively with simplified visual information. Communication supports reduced their anxiety. Staff recognised the importance of adapting communication, and AAC enabled expression of needs, concerns, and questions. So, what are the implications then for practice? Cancer prevention requires a multi-level ecological approach. The findings suggest that accessible communication must be embedded in all healthcare interactions. Staff require training in AAC and easy read approaches. Screening programs must adapt to meet the communication needs of people with intellectual disabilities, learning disabilities, with higher or lower support needs. So co-production is essential for meaningful engagement. So a conclusion, even though it's a bit long, in conclusion, as Oliwia said, there is an implementation gap. And as we reflect today on what has been learned from this session, AAC, easy read and communication supports were very helpful and effective during that workshop. And participants understood cancer education and screening from the feedback they gave us at the end of the session. And it became clear that communication alone is not enough. It is beyond words, as our titles suggest. As Dr. Martin McMahon and Dr. Kalia Yasmin Lima, in their presentation, the numbers behind the needs last week was excellent. and they suggested it should be a multi-system level approach. So to make meaningful progress in cancer prevention for people with intellectual and developmental disabilities, we must take this broad system level approach. At the individual level, with people with higher or support needs can benefit from clear, accessible information and communication supports. At the interpersonal level, the role of family, support persons, educators in helping to prepare people for cancer screening and prevention. At the organisational level, the workshop in Custachet highlighted the need for healthcare and education services to routinely provide easy read materials and integrate AAC practices into such training. At the policy level, alignment with national screening programs and broader strategies such as informed by the World Health Organization in cancer in terms of diagnostic overshadowing and the attitude and awareness of disability continue to shape the healthcare participation in cancer screening for people with intellectual disability. The workshop in Custachet demonstrated what is possible when communication is appropriately adopted, but also highlighted that sustainable change requires coordinated action across all levels of a system. The workshop provided a practical example of how accessible co-produced communication approaches, as discussed by Oliwia, can improve engagement with cancer prevention, education and screening for people with intellectual disabilities, learning disabilities, or higher or lower support needs. However, and I'll finish with this, sustainable change requires a coordinated, system-wide response across multiple levels of influence. Cancer prevention for people with intellectual disabilities must be addressed through a coordinated, ecological and multi-level approach that embeds communication, accessibility across all levels of health of the healthcare system. Thank you. And there's the reference for Bronfenbrenner and the easy read as well, checker, I think, which would be very beneficial. And we'll share that information with Francoise and Vladimir later. Okay, thank you.
Great. That was really, really valuable. Thank you, Margaret, for sharing this experience. And I'm looking at the chat and can see 2 questions. Both are for you.
Oh.
What age were the participants of the workshop?
Oh, so they were 18 years or older and they had higher and lower support needs.
Okay. And in relation to consent, did you experience any challenges?
No, because each person there had a support person with them and they explained it, and it was explained in Slovak, and then we showed them the website where their picture are, and they were delighted. In fact, they just wanted to get into pictures and say yes to everything. It was just an amazing and life-changing experience for me. Yeah.
For sure.
Thank you.
The communication is challenging between people. Communication about cancer is challenging even more with people with intellectual disabilities as well. And combining it all in one is doable.
Yeah, it's doable.
Yeah.
It takes a lot of work, as you know, Olivia, and in our work together over the last 3 or 4 years, it takes a lot of work, but I think we're getting places. And I certainly,
Absolutely.
I'd like to say hello to Bernadine.
Greetings
Hello.
from Ireland. How are you, Margaret, my long lost friend? How are you?
Oh my goodness, she's a blast from the past.
That's
Thank
right.
you. I'm
Thank
doing
you.
good. And how are you?
Great altogether. You're looking mighty, and I'm really interested. I wasn't able to go to the previous sessions because of
Yeah.
work. But I saw it again advertised last week, and I thought that has to be pencil. I didn't know you were there at all. But it's amazing. It's really brilliant to listen to what you're doing. It's fabulous work.
Oh, we're just
Fabulous
coming
work.
to the end of the project now, aren't we, Olivia?
Yes, we are. And if this topic is of interest, we are inviting you to the next session,
Brilliant.
the next webinar, 27th
Yes.
May, doing research right, ethical standards in practice. It is in the chat as well. Same
Brilliant.
time, same Cupid project. It will be
Absolutely
delivered
brilliant.
by Vera, our colleague from WG3.
Yeah.
Fantastic.
Perfect. Good. Well, I think
No
our
more
time's over.
questions.
But
Yeah.
if we don't have any more questions, it was really nice to discuss this topic and present what we've done, what we've managed to do, and present our research interests to you. Thank you for joining us today. And you're all invited to join for the next webinar, 27th May.
Yeah.
Brilliant.
Thank you so much, everybody, for attending. And God, it was just great. Thank you.
Thank you too.
Thank you.
Okay, thank you.
Thank you very much.
We'll be sharing the link for the next webinar in the next few days.
Fantastic.
Okay.
Brilliant.
Yeah.
Slam.
Okay.
Bye-bye.
Bye.
Goodbye.
Bye-bye.